Welcome, everybody. This is Point to Point, which is a discussion forum that we started a couple of years ago within CyberSight, which of course is a part of Orbis. I'm Malik, Kahook, professor of ophthalmology, vice chair of ophthalmology at the University of Colorado. This is, as I said, the second year, about 7th episode that we're doing, and I'm really excited to keep this going, especially during these difficult times during the pandemic, where we can still see each other interact and share information and teach each other in a forum that allows us to invite panelists who are experts in their field. And we have two great panelists today with a topic that I think will be of great use to really all ophthalmologists. So the discussion is going to be centered around 24-hour IOP, as well as monitoring devices, not distinctly just for glaucoma specialists. I think this can apply to comprehensive ophthalmologists and anybody seeing patients who might be dealing with issues around IOP. We're lucky enough to have, as I said, two great speakers. The first talk is going to be given by Dr. Arthur Sitt, who's professor of ophthalmology at the Mayo Clinic in Rochester, Minnesota. He leads the glaucoma service at the Mayo Clinic. Arthur is a mechanical engineer by training, so hopefully he won't get too mathematical on us during this discussion today. Many publications in the field of aqueous humor dynamics, that's going to be the focus of his talk today, so I look forward to that. The second talk is going to be given by Dr. Kaweh Mansouri, who is a consultant ophthalmologist at the Glaucoma Center Mansouri Clinic. Hopefully I said that okay, Kaweh. He's also part of our faculty here at the University of Colorado and has been for quite some time, a very valued member as an adjunct professor of ophthalmology. Kaweh is one of the world leaders in monitoring devices centered on 24-hour IOP. He did a lot of the early work with Triggerfish, Sensimed, and more recently with implant data. So very excited to hear what he might have to offer, not just from a novelty standpoint about devices, but also practical implications from a clinical application standpoint. What do we do for patients when we want 24-hour IOP data? To go through both of their CVs, I think would take up most of this hour. So I invite you to take a closer look. One thing I do want to mention is that, so I'm going to hand it over to Arthur for the first talk, and welcome Arthur to Point to Point.
Thank you, Malik, for that very kind introduction. I don't know how much of it is deserved, but it's very nice to hear. So my talk today will be on 24-hour IOP, and more specifically, why does IOP vary? And this is going to be an aqueous humor dynamics viewpoint. And so really getting into what causes the variations that we see over a 24-hour period in intraocular pressure. And as Malik mentioned, Dr. Kahook will, or Dr. Mansouri will then go on to talk about some of the devices and some of the clinical implications of these IOP variations over the 24-hour period. These are my disclosures, some of which are relevant. All of us deal with IOP, and most companies in the glaucoma space deal with IOP. So just to start off, all of us have seen statements such as this: reduction of intraocular pressure is currently the only effective treatment for glaucoma. And that's true. And we see this written in a lot of papers, and really with glaucoma, that is still what we're primarily focused on. But how much do we really know about intraocular pressure? Well, we know it's dynamic. We know it changes over time, but really how dynamic it is was shown to us very clearly 25 years ago now by Jay McLaren and Richard Brubaker when they implanted telemetric monitoring devices into the eyes of rabbits. And this allowed them to measure 24-hour patterns in these rabbits and see what really happens. And what they found was remarkable. They found that intraocular pressure varies constantly, it varies rapidly, and by very large magnitudes. And you can see here in a single rabbit that there was a circadian pattern with the pressure being lower during the light phase and higher during the dark phase. And then more recently, Crawford Downs and his group has updated this technology and placed it into the eyes of non-human primates. And they found really the same thing. IOP varies constantly, rapidly, and by large magnitudes. Interestingly, non-human primates do not seem to exhibit a circadian pattern. So over the decades where we've been looking at intraocular pressure, there have been a lot of things that have been implicated as contributing to the variations. And this is just a small list. We're not going to go through all of this list today since we don't want to be here for the next 2 weeks. So really what I want to focus on are a couple of things: body and head position and circadian rhythms, so the 24-hour pressures. Now let's first talk about the circadian pattern of intraocular pressure. And a lot of this seminal work was done by John Liu and Bob Weinreb at the University of California in San Diego. And what they did was they set up a sleep laboratory where they brought in subjects and patients, and they measured the pressures using a pneumotonometer in the habitual position. So that means you measure it during the daylight period while patients are sitting upright. And then during the nighttime period, you do it while they're lying down. And what they found was that over the course of the day, the intraocular pressure tends to start a little bit higher in the morning and gradually decrease as the day goes along. But then when individuals lie down to go to sleep, there's a marked increase in intraocular pressure. And that was certainly true in normal individuals. And then in untreated glaucoma patients, they again found a similar pattern where intraocular pressure decreases slowly over the course of the day and then increases significantly when individuals lie down to go to sleep. Now, interestingly, they also measured supine pressures throughout the entire day. And what they found is if you eliminate these changes in body position, then the nocturnal spike, nocturnal rise largely disappears. And certainly in the case of normals, it seems to flatten out. And then in the case of glaucoma patients, the nocturnal pressure actually ended up being a little bit lower than the diurnal pressure when you look at the supine only position. So what does that tell us? It tells us, first of all, and most importantly, that body position matters for intraocular pressure. So how much does it matter? Well, some investigators have gone to extremes and they've looked at things such as the yoga headstand position. And if you were to take this extreme body position, pressures can increase by a factor of 2. It can double. And that happens immediately after taking that position. It happens if you sustain that position. But then when you go back to a normal position, it does return pretty quickly to the normal pressures you would see sitting upright. Now, it's not just the very extreme body positions that can affect intraocular pressure. This more recent study looking at various different yoga poses found that pressures can increase from 25% with just a leg up position to 28%, 48%, and then 79% with this common downward dog type of position in yoga. So looking at these variations, we decided a number of years ago to try to systematically try to understand what were the head and body positions that actually affect intraocular pressure. So we got a group of young, healthy volunteers, and we measured them in a number of different positions. So first of all, we know that intraocular pressure will tend to decrease if you measure it repeatedly. So what we did is we looked at a number of sitting positions and a number of recumbent positions. We randomized those, and then we randomized the sitting positions, and we randomized the recumbent position. So we eliminate the effect of repeated measurements, and we measured by pneumotonometry, gave 5 minutes in between measurements. And this is what we found. So first of all, head position does matter. If you have neck extension, that results in an increase in intraocular pressure compared to sitting with your head in the neutral position at the slit lamp. If you measure neck flexion, that also causes an increase in intraocular pressure compared to having the neck in the neutral position. And then neck flexion seems to increase the pressure more than neck extension. And then body position matters as well. So all of the recumbent positions that we measured had a greater pressure than sitting upright with your head in the neutral position. In the recumbent positions, though, we did not find a difference between supine or right and left lateral decubitus as a whole. Now, when we look at the lateral decubitus positions, though, it does seem that that even that position can affect which eye has the higher pressure. So in the right lateral decubitus position, there was a trend towards having the right eye, the lower eye, having a higher intraocular pressure. And then in the left lateral decubitus position, it did show that there was a significantly higher pressure in the left lateral decubitus position in that left or lower eye, in the dependent eye. And subsequent investigators have also looked at this in other populations and confirmed that the dependent eye, the lower eye, has the higher pressure. So this does bring up a number of questions. So first of all, if the pressure is higher in the recumbent position, should we have glaucoma patients sleep with their head elevated? Another question is, a lot of patients will tell me that they sleep with a couple extra pillows, and is that actually detrimental by putting the neck into flexion? And then third is the lateral decubitus positions. We see many, many patients with asymmetric glaucoma, and is this potentially contributing to that? And just to give you some data from a more recent study, this was a study looking at pattern ERG, and what they looked at is the pattern ERG amplitude in different body positions, and they actually found that in the lateral decubitus positions, the dependent eye, the lower eye, had a lower amplitude compared to the non-dependent eye. So there does seem to be some functional implications to even that small pressure change in the lateral decubitus position. Now, that being said, the clinical significance of ILP changes with body position still remains to be determined, and that will get into some of the devices that we hope are coming down the road. But what I want to talk about a little bit next is, well, what actually causes these changes in intraocular pressure? So let's start talking about aqueous humor dynamics and body position. We know that aqueous humor flow follows two pathways. There's a trabecular pathway where aqueous humor exits through the trabecular meshwork into Schlemm's canal out through the episclerovenous system. And there's also the uveoscleral pathway where it goes across the iris root to the ciliary body and then out through vessels in the sclera. And this can be modeled with the modified Goldman equation, which relates intraocular pressure to aqueous humor flow rate, uveoscleral flow rate, outflow facility, and episclerovenous pressure. So how do we actually measure these? So outflow facility is measured with tonography. Typically, it's been measured with a Schiotz, an electronic Schiotz tonometer. Those no longer exist. We built a digital version of that. It can also be measured with pneumotonography. Essentially, what we're doing is we're placing a weight on the eye, raising the pressure, and looking at that decay of pressure over time, and then using the Friedenwald equations and tables, we can then calculate outflow facility. Aqueous humor flow rate is measured with fluorophotometry. We place a drop of fluorescein or a few drops of fluorescein on the eye, form a fluorescein depot in the cornea and the anterior chamber. And then over time with aqueous humor flow, that depot decreases. And then using a fluorophotometer, we can scan the eye and look at the change in fluorescence over time. And that allows us to calculate aqueous humor clearance, aqueous humor flow rate. Episclerovenous pressure, we measure using our device that you see here. We place a balloon on the eye and that compresses the episcleral veins. And you could see that vein right there, that's an episcleral vein blanching as the pressure increases. Then we do some image analysis to find out the pressure at which that vein just starts to collapse, which corresponds to episclerovenous pressure. And then uveoscleral flow cannot be measured non-invasively. So in humans, we calculate that from the modified Goldman equation based on the other parameters that we can measure. So what do we know using these techniques? So Dr. Brubaker had for a number of years a tilt table where he took medical students and put them into interesting and uncomfortable positions. And then he measured the effect of this in one study on aqueous humor flow. And what he found is if you had a slight tilt, it really didn't affect the aqueous humor flow rate. But when you have that tilt head down position, the intraocular pressure does increase as you would expect. And then if you had a very large tilt, you had a very large increase in intraocular pressure. But again, really not much of a change in aqueous humor flow rate. In fact, if anything, there was a small decrease in aqueous humor flow rate, which would suggest that the pressure should go down, but instead it goes up. So clearly the aqueous humor flow rate is not what controls changes in pressure with body position. We also looked at outflow facility, and we got some volunteers, and we measured outflow facility in the supine position and the sitting position, and we didn't find any difference in outflow facility between those two postures, although we did find a significant difference in intraocular pressure as we would have expected. And what about body position? So EVP currently, with our previous device, could not measure EVP in the true supine position, but we did manage to get a group of volunteers who could take this uncomfortable semi-prone position where they put their head in a slit lamp, and we did measure episclerovenous pressure, and intraocular pressure. And what we found is that in that semi-prone position, intraocular pressure increases, but episclerovenous pressure also increases, and that change in ILP and EVP were similar, and that suggested to us that the change in intraocular pressure with body position was due to EVP changes. Now, we do have a new device where we can start to measure in the true supine position. We're just starting studies with that device. Now, just getting back to the circadian pattern of intraocular pressure again. Just to remind the audience, if you measure the intraocular pressure over a 24-hour period in the supine-only position, it stays relatively stable through the 24-hour period. And that's actually very curious, because when Dr. Brubaker and others and our group as well have looked at the aqueous humor production rate, that actually drops by about 50% at nighttime. So if everything else stayed constant, we would actually expect a marked decrease in intraocular pressure, and not this relatively constant pattern that you see once we eliminate body position. So again, a number of years ago, we started to try to understand what causes this. And we took a group of healthy volunteers with regular sleep patterns. We measured aqueous hemodynamics using pneumotonometry for ILP, anterior chamber fluorophotometry for flow rate, digital sheet stenography for facility, and our venometry technique for EVP. And we measured their aqueous hemodynamics during a mid-diurnal period from 2 to 4 p.m. and a mid-nocturnal period from 2 to 4 a.m. And we compared those using generalized estimating equation models. And this is what we found. So first of all, aqueous humor production does drop by about 50% at nighttime, and that was expected based on previous studies. Intraocular pressure does not change significantly from a daytime to nighttime when you eliminate the body position changes, and it's true in the seated position as well as the supine position. Outflow facility, however, does decrease at night, not a huge amount, but by about 15%, and it was a statistically significant decrease in outflow facility, so that definitely can contribute to increasing ILP. EVP, there's a lot of variability in this type of measurement, but there was no difference between day and nighttime. And then plugging all these parameters into uveal scleral flow calculations, what we found is that during the daytime, we had about 38% of flow through the uveal scleral system, which is typical for healthy adults. During the nighttime, though, it dropped down to 5.6%, and the actual decrease in flow rate through the uveal scleral system was very significant. It's over 90%, and that was a significant change. So what this tells us then is that episclerovenous pressure really does not change from day to nighttime, but the pattern of pressures that we see where the intraocular pressure stays essentially the same over the 24-hour period when you eliminate body position is due to a decrease in outflow facility and an increase in decrease in uveal scleral flow rate at nighttime. And what that does is it compensates for that very significant 50% drop in aqueous humor production. And so ILP, therefore, stays stable throughout the 24-hour period, essentially, when you eliminate body position changes. So just to summarize a little bit, ILP elevation with body position seems to occur due to changes in episclerovenous pressure and elevation in episclerovenous pressure, which mirrors the change in ILP. There is a circadian pattern to intraocular pressure, with ILP being highest at nighttime in most individuals when measured in the habitual positions, sitting upright during the daytime and lying down during the nighttime. And then that ILP elevation is due to body position, decreased uveal scleral flow rate at nighttime, and decreased outflow facility. So thank you very much, and we'll stick around, of course, for Dr. Mansouri's talk, and happy to answer questions afterwards.
Great. Yeah, thanks, Arthur. Lots of information and lots of questions coming up that we'll have to go over after Kaweh is done. Just another mention here that I think is worth connecting the dots. So we heard a lot of mention of UCSD and the time that Arthur spent with Weinreb and the 24-hour lab there, the sleep lab there. Kaweh had similar experience. He spent a couple of years in San Diego learning from Dr. Weinreb, and I think you're going to see some of that influence here. We're going to get into a more clinical-based discussion, 24-hour IOP in our patients, and also novel devices that can be used for getting those measurements in an accurate way. And I'll hand it over to Kaweh for his talk. Welcome, Kaweh.
Thank you very much, Malik. I'd like again also to thank you for organizing this event, and thank Orbis for it and for the invitation to speak here. Arthur has prepared so nicely the terrain, giving you very comprehensive overview of where we stand about aqueous hemodynamics and physiology. I will speak, as was mentioned, a bit more about where we stand now in practical measurement and if there are devices which are ready for the clinic and which we can use and how we interpret the data that we get. These are my disclosures. 2 of them are relevant. I have been a consultant to Sensimed, which produced the triggerfish, and I'm a consultant to implant data. When we speak about glaucoma, we speak about 3 pressures. Of course, IOP, but we also speak about intracranial pressure, the pressure behind the eye, and the ocular perfusion pressure, which is often the resultant of the 2, if you like. Now, for the time being, IOP is still the only treatable pressure and the only treatable risk factor in glaucoma. Our best method to measure it has many shortcomings, and it was no one else than its founder, Hans Goldmann, who knew about the many limitations of its eponymous tonometry technique. The most important one is that GAD provides just a snapshot of IOP, a few seconds out of a whole year of glaucoma, repeated maybe several times a year. And we know, as Arthur beautifully showed, that IOP is a very dynamic parameter, and it varies from minute to minute according to a host of extrinsic and intrinsic events and parameters. Unsurprisingly, because of this instability of IOP, we measure peak IOP in probably more than 2/3 of our patients. And as a direct result, we see axonal injury occur at what we consider to be normal IOP levels in 50% of cases, or maybe even more. One reason why IOP varies is that, contrary to these beautiful animals from the zoo in San Diego, when we humans go to sleep, we change our body position from upright to supine. And this itself creates an IOP increase, and the mechanisms behind were just mentioned by Dr. Sid. IOP, therefore, is a sleeping giant, and I think it was Arthur who coined this term. It's a sleeping giant because it's often at its highest level during the nighttime period in all kinds of people, healthy, young, healthy, old, and glaucoma patients. Very few of us have a different circadian rhythm. I say very few because not all of us react in the same manner. We cannot all be considered as averages, and we have our individual rhythms that change also over time, and that can change according to our occupation, or according to our pathology, according to our glaucoma treatment. Therefore, having devices that can measure IOP for 24 hours and ideally longer are important. You've all heard about the triggerfish contact lens. I'll speak about it briefly. And some of you may have heard about the implantable sensors, and I will speak about the iMate device where we have clinical data. The triggerfish was developed by 2 young PhD students from my city, Lausanne, in the 2000 years. And they started a startup, and the device was based on the principle that strain gauges in a silicone contact lens can measure IOP changes. We found out that they measure also the volume changes in the eye, which are different from IOP changes, and that they are very much affected by biomechanical properties of the cornea. So those were some limitations and some advantages too. The main limitation was that the device didn't provide IOP in millimeter mercury. However, it was deemed important enough of a breakthrough to be featured in the Economist journal back then in 2011. The bench testing showed great results, 1-to-1 comparison between manometry and the device readings. But humans are not animals, are not enucleated eyes. They're much more complex. So you need to come up with data to prove your point. And data was forthcoming in many studies from different centers that showed the device to be safe, that showed it to be quite reproducible. And here's an example of what the device provided you. It provided you relative changes of IOP-related events in the eye over 24 hours. Often the highest measurements were during the sleep period. This is the gray zone in the middle. Patients sleep, IOP goes higher, as Arthur just showed. But not everybody reacted that way. The problem was, how do you interpret those data if they're not in millimeter scales? Nevertheless, the FDA approved the device after the studies were conducted, but gave it kind of a challenged indication of use, which I read to you here. So the triggerfish is a prescription device indicated to detect peak patterns of variation in IOP over a maximum period of 24 hours, which then, however, which then were needed to identify the window of time to measure IOP by conventional, meaning Goldman, for example, methods. So in essence, you could use a contact lens, then you would see where the peak IOP is, usually at nighttime, and then you would need to confirm it with GAT. So this was an impossible formula, and the device didn't really catch on clinically widely. We still use it in our center for some select cases. So we need to have a device which is easier to use, or easier to interpret. And this is maybe where the implantable sensors come in also. The iMate device, that's a German startup company, is an implantable sensor that can be used during cataract surgery, and it will be implanted into the sulcus just in front of the lens. The device was CE marked many years ago, and quite a good number of studies show that it is safe to use. This is how it looks. That's the ASIC. You have pressure sensors embedded in what looks like a small computer. It's implanted in the eye. The patient has an external reader that, when powered, sends energy to the device to power it, and it receives the measurement in return. Importantly, there is no battery in the sensor, which would need to be replaced. So no battery, the device can stay in the eye for theoretically ever. Actually, there are some patients in Germany now that have had the device in their eyes for up to 10 years. The first generation had some adverse events. It was a bit bulkier, and it created some pigment distortion immediately after surgery. That wasn't ideal because the pigment could itself clog the angle, of course. As the device was miniaturized, the surgery technique was improved. This did not seem to be happening. Now, so patients have it in their eyes, and there are about 70, 80 patients worldwide in Europe who have the device in the eye, some of them for, as I said, up to 10 years. Do they obtain measurements once the study period is over? Well, look at this case. This was a patient over 950 days. And patients for the first year, the study year, were asked to measure 4 times a day at least. But if you look at this graph, you see that beyond the 50th day or so, patients still continue to measure at least 4 times, some of them more than 4 times a year. So patients believe that device measurements are useful for them, not just for science. So that's important. How could those measurements correlate now to Goldman applanation tonometry? Well, these are different statistical methods, but what you see here is that the concordance is between iMate and GAT is very high, and it's somewhere between 78 and 88. Very good correlation. You may even ask the question, well, is GAT the right device? Is it the real gold standard? Which device measures the real IOP? The one that's in the eye, the sensor, or the one that's outside the eye, that has to go through the cornea and through muscle pressure and sclerorigidity issues and so on? But that's another discussion which we won't have here. So the measurements seem to be very reliable. Again, look at the same case of the patient I presented before who measured over 3 years and beyond, and you see how a typical IOP curve can look like for the long term. You can pick any single day, and you see the wide variation of the measurements obtained. On any single day, essentially, the pressure could be as low as 10 and as high as 20 or 22 in a well-controlled glaucoma patient. So it shows you the variability of IOP and the importance to have more data so that you can average out and get a better image of the patient's real 24-hour IOP variations. Here we looked in the same patient whether there were differences in daytime throughout those 3 years. And yes, what we see here is, if you look at the circle on the left, that the highest measurements occurred at around 4 a.m. And this is very comparable to what we have seen previously using the contact lens sensor here in the middle, where again, the highest IOPs were between 3-4 p.m. Or what the sleep laboratory in San Diego obtained over many years. Again, peak IOP on average around 3-4 p.m. Thanks to Arthur Sid's talk before, we understand now why IOP is higher, sometimes much higher at nighttime in the majority of people. Because the first generation and the first approach was only for cataract patients and made cataract surgery slightly more complicated, we wanted to have another sensor for glaucoma patients who do not need to undergo cataract surgery, who had it before, but who need glaucoma surgery, filtering surgery. And here we came up with the so-called iMate SC for suprachoroidal. It's essentially the same approach, but it's a rectangular shape. And the idea is to place it during non-penetrating glaucoma surgery as a space maintainer. It was CE marked recently. So here is the video from my first patients from 2 years ago. So we are doing a deep sclerectomy here. You see here, we have opened the conjunctiva, the mitomycin is being applied. We take it out, we rinse, of course, and then we will dissect our regular 5 by 5 millimeter scleral flap. Let me jump. So here we're going all the way into clear cornea. Now we are dissecting our deep flap, 4 by 4 millimeters. So far, so regular. Once we go to the cornea, we'll take it away. And then we will dissect the trabecular descendens membrane. And after we have done the regular part, this is the new part. So we create a small opening into the suprachoroidal space. As you can see here, we inject viscoelastic device to create a pocket where then we will insert our SC device. You see the SC sensor, it's the first generation, the current generation is a bit bulky, 3.5 to 7.5 millimeters in length. But as you can see here, although this was my first case, it's not much of a challenge to insert it. So you have the posterior part that will be in contact with the choroid, which measures IOP, and this is the external side of it. So it has been put in place. Okay, sorry, my video is jumping here. So it's put in place, and then we close our flap, we close our conjunctiva, as we usually do. So the surgery itself is very similar to the regular surgery. Instead of using an inert space maintainer, such as the collagen implant or the Esnopa implant, we put this smart space maintainer. A multi-center study was conducted, 5 centers, Germany, Switzerland, and the results were very positive. This is again the same case that you just saw, the first postoperative day. The eye looks good, just as any regular eye would do. This is an swept source OCT image where you see the device in situ. You see it creates a nice opening inside the sclera. And this is the patient on the first day, happy and smiling. And we could right away, after the patient went home, see how the measurements were, because the patient now could use himself, his external reader, to obtain IOP measurements at home. And here you see a comparison between the first 6 months of a GAT measurement on the y-axis, and then the blind Altman method as well with the SC. And you see that the correlation between the two was very good, and it was plus minus 5 millimeters of mercury from each other on most occasions. Is the device safe? That was, of course, an important issue because you're using a new big space maintainer. Fortunately, we did not have any serious adverse event. We had one case of choroidal detachment, which resolved under medical treatment without surgery intervention. And otherwise, we had very similar adverse events than we usually see in non-penetrating glaucoma surgery. So with the sensors, we get a lot of data. And what you see here is the biggest treasure trove, biggest collection of IOP data, I think, of all times. From 22 eyes that had the iMate sensors in their eyes, we had 92,000 measurements over 15,800 or so measurement days. We wanted to know now if IOP, even when you have so much data, if IOP is repeatable over the short term, less than 3 months. And what we found was that the repeatability of IOP measurements was moderate, with an ICC of about 0.5, 0.6. So even the short term, IOP measurements are not very repeatable. Even if you see your patient every 3 months and you do a GAT, or you do even a diurnal tension curve, it's still not very repeatable. What about long term? Well, long term repeatability is even less. It's very poor. You see that the ICC values for long term, meaning over a year, IOP measurements are 0.2 to 0.5. What does that mean? It means our current practice of measuring IOP every 4-6 months really provides us a very poor snapshot of real IOP. We need much more IOP measurements. We need continuous measurement. Something we could also learn from all these measurements is whether in our sample of patients there was a difference between weekdays. No, we didn't find any, neither for average IOP nor for peak IOP. However, we found a significant difference between seasons. We found that the lowest IOP measurements were in the summer months, June, July, and this difference to winter was significant. Essentially, IOP in winter turned out to be about 7% higher than in summer. Now, you may see this is not huge. This doesn't have a practical implication. Well, probably it does. These are averages again, and there may be patients where the difference between summer and month is much larger. Or imagine studies in new medications comparing one to another. So in large pharmaceutical studies, this difference between seasons may have implications. Another lesson we learned is that now we can study what happens in the eye in patients who undergo intravitreal injections for retinal problems. Here we had a patient who had glaucoma. That's why he had the sensor in his eye, and he had to go regular intravitreal injection. And we were worried initially that his IOPs would go very high. But once he measured at home with his IOP sensor, we found that it went the other way. After each injection, his pressure went down, sometimes to 0. And then it recuperated over the 2-3 days following. And it almost never went high as we had expected. So giving him a Diamox preventively, at least in this case, doesn't make sense. So that's another advantage when the patient can measure his own IOP. And this can have practical management advantages. So Dr. Kahook asked me to provide you some actionable pearls. Well, it's not very easy because most of these devices are not available outside of Europe for sure, but even to the most of glaucoma specialists or comprehensive ophthalmologists. But we have implantable sensors, which we can use in some select centers, and I'm hopeful that in the coming days they will become more available. In the absence of these sensors, and by the way, I presented only 2 approaches, but there are other approaches. I presented the 2 where we have published clinical data. Fortunately, we have other approaches to injectables. One such company, InjectSense, active in the US, is a promising startup as well, and we hope to see clinical data soon. But in the absence of routine access to these devices, we can perform a diurnal tension curve. It's better than just obtaining a single IOP measurement. It's better than nothing. But ideally, you would expect your patient to be sitting in your waiting room and be happy from 8 to 6 p.m. Well, that's not the case. It's cumbersome for patients, to wait the whole day and see other patients come and leave. They get tired. They have other things to do. They may not appreciate to spend the whole day in your clinic for a few data points. But still, I would say it's worth trying if patients are willing to undergo this diurnal tension torture. We have access to home tonometers. The eye care home tonometer, this is generation 2, is such a device which has been approved, which works reasonably well. However, not every patient can use it. About a third of patients will never manage to use it because of arthritis problems or other problems. But that's another approach which provides us additional IOP data points outside clinic hours at the patient's home during different activities. So it's still better than not obtaining any more measurement. I think these are actionable pearls. Try to get more IOP data while you're waiting for sensors. What do I hope will these technologies provide us? Well, I think we can obtain better management of glaucoma. If we really go to using sustainable release IOP medications more routinely, where patients might not come to the clinic as often as we would like to, or as often as they did, because they don't need to renew their prescription, well, having a home monitoring of the IOP would be useful. What I personally think is one of the biggest advantages of patients measuring the IOPs at home is that now they can visualize a disease which is abstract, glaucoma. It becomes less abstract by having measurements themselves, and I'm sure it will improve the adherence to medications. And by improving adherence to medications, by being able also to see if there is an IOP peak or not, they may feel better in control, empowered, and have a better quality of life. By the way, speaking about what we can do with home monitoring, during the first lockdown phase of COVID, where in Germany, in Switzerland, in many countries, patients were not supposed to come for routine visit, those patients who had a sensor in the eye could still measure at home and transfer the data to their physicians. And we looked at these patients, 34 of them, and we found that their physicians were very happy to have access to the data, and that during 2 months of lockdown, these patients could benefit from better glaucoma management without leaving their home. In some cases, even, the data led to an immediate treatment change, different medications, or one case of surgery was deemed urgent to be conducted. These were patients who otherwise would have lost probably 2-3 months. And finally, there will be challenges. Of course, we need to be sure that these implanted devices are safe for the long term, not just 5, not just 10 years, but longer. We will need to learn to how better use the data, how to optimally interpret the data, and we will need probably to challenge ourselves and reevaluate our practice patterns. I'm sure that reimbursement after all these challenges would be a mere formality. Thank you very much.
2 great talks, and I think it tells a whole story from the basic science start all the way through to what are the things that you could do during a pandemic with IOP monitors, which I think is, it's introducing new questions, but it might be accelerating the science as well as the clinical application, because we're starting to recognize the benefits in a more real world way. I have a ton of questions. A lot of them came in before the meeting. I'm getting texted and messages on WhatsApp from some of the attendees. A lot of hellos to you from around the world, which is one of the nice parts of doing a cyber site session. We get people from all over the world attending. I'm going to start off with a question for Arthur that Kaweh just touched on, which was asked several times pre-meeting by the attendees, which is, hey, it's great to have these nice, fancy toys that we might get our hands on in the future. But, Arthur, what do you do in clinic? I think Kaweh described it as DTC torture. So do you do diurnal tension curves, or what would you recommend to people in private practice, maybe in low resource areas? What can they do?
Yeah, and I think Kaweh really did touch on it and address it. And unfortunately, there isn't anything that's great right now. I actually perform diurnal tension curves much less frequently than I did, say, 10 years ago. There's been some good work, one study from Tony Riolini showing that the repeatability of diurnal tension curves is poor, and then the work that Kaweh showed, again, the repeatability of IOP measurements from day to day is poor. So I just didn't know how to interpret diurnal tension curves in most patients. So there's a very small number of patients where I still get that, just to see if there really are very, very large swings in intraocular pressure. And then obtaining home IOPs, as again, Kaweh mentioned, is difficult for most patients. The eye care home, I really don't use outside of studies right now. And for studies looking at select patient groups, I think it's great. But it is again kind of difficult for a lot of patients to use, and then they don't see the data immediately. So that's it's a potential dissatisfier for patients continuing to use this on a clinical basis. There are some things that could potentially be done. There are some individuals, Remo Susanna in particular is a very strong advocate of provocative tests, such as the water drinking test, and that does show that there's an increase in IOP when you drink a large volume of water. And there definitely are some studies that show more of an increase in patients with worse glaucoma. Again, I don't do that clinically, just because it's too cumbersome in a routine clinical basis. So unfortunately, the answer right now is stay tuned. The technology is coming fast. There's clearly the work from and the devices from Sensimed and Implant Data have been pioneering, but there's a new generation of devices that are coming that I think will get us to the next stage. And Kaweh mentioned Inject Sense, and there's other companies as well.
Right. And Kaweh, maybe you can touch a little bit on eye care. Are you using it in clinical practice or studies, clinical practice routinely? How do you think of eye care?
First of all, I agree with Arthur's points. Also in my practice, the diurnal torture curve is not widely used. We may use in 5% of our patients because it's cumbersome, because they don't like it. And also, again, because the data is of only small use. So the cost benefit is not wide. And the eye care is a device which we had in our clinic, the eye care home, and we rent it or we give it to patients so far free of charge, but we may have to revisit this issue because it's costing us. We give it to them for about a week or two to measure at home. After they undergo about half an hour training session in our clinic. To whom do I give it? Do we give it? Well, it's mostly patients where we see glaucoma progression already, despite low pressures during the clinic. And we either do it for ourselves, to more for academic reasons, because as I mentioned, the progression is there. So you need to change your management. Or we give it to them because they're hesitant to change their management or to undergo surgery because, they tell me, but my pressure is 15, it's 14, you tell me it's low pressure. So why operate? So we provide to them. And then if they manage to measure at home, oftentimes they see that there are swings. They see that pressure is not always stable and low. But again, the reliability issue comes up because you can never be sure that the patient at home measures just as correctly as you show it to him here in the clinic. So we don't know if the value that they measure are reliable. And frankly, we know it's hard to do. And we haven't had a good study where it's measured, for example, compared to the iMate, often enough to be able to obtain those measurements. But again, this is better than nothing. To go back to what I said, the more data you get, the better, as long as you can assure that the quality isn't bad.
Yeah, I think that the more data might be better. That question, I found myself in the clinic scratching my head saying, maybe I have too much eye care data because I don't know what to do with it. And it's not giving me the information that I thought. I will tell you, we do use eye care here routinely. And we found a way to actually plug patients into getting the device and getting trained on the device outside of clinic. That's one of the major issues, right? So we're all busy in clinic. How do you educate the patient on how to use it? We have several technicians that are trained. We actually use it as part of our electronic medical record to get them plugged in, just like for an MRI or a CT scan. They go and get trained and then use it for a week. Cost is an issue. We're lucky to have some devices that we can cover the cost of for some patients, but for others, it is an issue. One question that came up was the reliability of eye care. And maybe I'll go back to Arthur here. Do you see eye care as being as reliable as Goldmann? Is there a difference between the two?
So there is a difference, and this gets into another area of ocular biomechanics. So eye care clearly has some advantages in certain patient populations, like a pediatric population where you can measure pressures without putting anesthetic, and patients who are maybe have blepharal spasm, and this is a good way of getting those intraocular pressure measurements. But it does seem to be more affected by central corneal thickness. Goldmann clearly is, but eye care appears to be even more affected by central corneal thickness. So I think it's very useful, and I definitely use eye care a lot in my clinical practice. But those measurements are good for longitudinal measurements, but it's sometimes hard to compare if you're taking some with Goldmann, some with eye care. Those pressures can be a little bit hard to compare in some patients.
Yeah. What about?
We need to differentiate between the eye care taken by the physician in the office and the eye care home taken by the patient, where we really don't know. The one we take in the clinic, is quite reliable, comparable to GAD. The one that patients obtain home probably is less so, maybe even much less so.
Yeah, that's part of, once you give it to the patient and they have it in the home environment, many things can happen. What about pneumotonometry? Are either of you using pneumotonometry routinely in clinic on patients? Maybe we could start with Kaweh. Nope.
Well, we use it for studies. We think it's the gold standard, and it's really a reliable device. You get a printout, you can measure the supine position. So for research purposes, it's a perfect device. It's a very good device.
Yep. And Arthur, maybe a little bit of a twist for you. So for K-Pro patients, for example, what type of approach do you have, or patients with issues that might affect corneal approaches, PKP patients, or patients with corneal irregularities? What would you do?
Yeah, so I actually do use pneumotometry, not on every patient, but for those types of patients who where I think gold mine is going to be unreliable, who have irregular corneas. In K-Pro patients, you can't measure on the K-Pro, of course, but you can measure on this limbal sclera, and there is a good correlation with corneal intraocular pressure. So again, it doesn't tell you what the pressure actually is, but allows you to monitor it over time.
Okay, Arthur, there's some people who want to know if your EVP measurement device is commercial.
It's not, no. It's such a small market for it. There's probably, the number of people around the world who'd be interested in measuring EVP, I could probably count on one hand. So.
Yeah, well, you got me and Kaweh, so we're both we're both in line to buy it when it's available. Let me ask Kaweh, and actually this could be for both of you because you both worked extensively with John Liu and Bob Weinreb. We have a lot of studies that actually the three of us in some ways have tried to mimic with different settings. A lot of us are following in Bob's and John's footsteps. When it comes to 24-hour IOP control, maybe we'll start with Kaweh. Can you talk a little bit about the efficacy of SLT and Migs for 24-hour IOP control? And then Arthur, if you can add anything after Kaweh's done.
Sure. Well, to my knowledge, the first 24-hour study looking at the effect of SLT on IOP was done at the sleep laboratory by John Liu and Bob Weinreb in San Diego about 20 years ago, 15 years ago. And they showed that there was a clear reduction of nighttime IOP, which was more than we see after almost all medication classes except prostaglandins. So, and this is something that we later could confirm using the triggerfish. We also found a significant reduction at nighttime of SLT by SLT. Concerning Migs, to my knowledge, Malik, there hasn't been a real 24-hour study done with Migs. And we have had some data after glaucoma surgery, but this is standard glaucoma surgery with the triggerfish, but not after Migs. But this is definitely an important thing to do.
Yeah, what do you think, Arthur?
Yeah, no, I agree. And just to elaborate on the study that Kaweh mentioned, it was done while I was a fellow. So it wasn't quite 20 years ago. I'm not not getting to that area quite yet. But it was actually an ALT study. And what was really interesting about that particular study is that in that patient group, there was no change in pressure during the daytime. So if you were to look at those patients, you would have thought that they failed laser treatment. But when you looked at the 24-hour pressures, there was a clear flattening of that nocturnal peak.
Yeah, Arthur, that's a very important point. I end up mentioning that regularly when I do SLT, and I do a lot of SLT. And I tell my patients we determine SLT success after 2 months. And then after 2 months, if I don't see this 25% IOP reduction, which we usually would then consider an SLT failure, I often end up telling them, well, we put you on medications, but the laser wasn't in vain. It probably reduced your nighttime pressure, but we don't pick it up because we don't measure it.
Right. Yep. I often use that same line probably because I heard you saying it at some point. So we don't have a ton of time left, but I do want to get sort of rapid fire to a bunch of questions. Dr. Susanna's name was mentioned earlier. He's listening in. He sent a question about how to measure peak IOP in clinic. I think there are different ways to do it. So I'm just wondering if, Kaweh, do you try and get to peak IOP through different maneuvers in clinic, or do you not do that?
Well, I probably inadvertently do it all the time by asking my patients to do a visual field before they see me. Seriously. Anyway, so that's one inadvertent way to do. The water drinking test, which we sometimes use, not often, that's for practical purposes, is a validated method to measure peak IOP. It really has been shown by different studies from different places. That's it.
Okay. Arthur, do you do anything? There was this talk about supine and that might mimic the peak pressure. There are some papers on that earlier on. Do you do anything like that?
Not routinely. The supine measurement was something from Sameh Mossayed when she was with Bob Weinreb again, showing that rise in supine pressures did parallel the rise in nocturnal pressures in a lot of patients, but it's not something I do routinely.
How often, Arthur, do you talk to your patients about sleep position and the effects on IOP supine versus laying on one side or the other?
So the supine, I think, is trickier because we don't know how it parallels the other physiologic changes, such as a change in CSF pressure, change in blood flow. But I do talk to them a lot about the lateral decubitus position, there is clearly that increase on the one side, but even more significant, if patients are sleeping on their side and pushing their head against the pillow, you can have very, very large increases in intraocular pressure, and that was shown in a study, I think, from Hopkins. So I do counsel patients, if you're sleeping on your side, make sure your face isn't squished into the pillow.
Yeah, this is when being a doctor and knowing some of this may not be a good thing. When I see my son sleeping on one side, I'll often go and check that his eye isn't next to the pillow or push the pillow down a little bit. So that just an insight into some of my mental issues. So I have one question for Kaweh, and then I'm going to ask a final joint question here for two of you. So Kaweh, there's a question about different environments and when some of these implants might work. Space travel was mentioned in a question, scuba diving. Will the implanted IOP sensors work in different environments?
Good question. You know, if a year or 2 years ago, if I get a question from space travel, I would have said, who is the crazy person asking it? But you saw just yesterday, we had 2 new tourists, or today, sent into space. So the question is becoming relevant much faster than we think. Honest answer, we don't know. We haven't studied that. Scuba diving, also, we haven't studied that. We don't know. The whole scuba diving and IOP issue is not very well understood. How high does IOP go? Should we advise our patients against scuba diving? We had a whole course here in Lausanne a while ago, and we don't really know. And what I tell my few scuba diving patients is, you know, I have one patient who goes for 30 days a year. Is, you know, I don't want to prevent you from doing it. I know how important it is for you, but let's check your pressure afterwards, after your scuba diving week. And maybe if you want to take a Diamox or 2 during that week, don't hesitate. But we don't really know. There's no consensus. Things that we know more often about environments are if patients have a sensor in the eye mate, if they undergo a laser, YAG laser for capsulotomy, or goniopuncture, suture lysis, then you need to remeasure the pressure, and sometimes you need to calibrate the device. So a laser in the eye in a sensor can have an effect, not destroy it, but you need to recalibrate it. What about daily activities? That's another issue. We have a few patients who play wind instruments. We had them come into the office and play here with a silencer for half an hour, and we would measure IOP again. I usually I ask my patients who have high pressures or fluctuating pressures, how much coffee they drink. Often they say 8, 10 cups of espresso. I advise them to reduce a bit if they can. Yes, Malik, please reduce. And we know from beautiful studies from Tanuj Dada in India that meditation really has validated IOP reducing effects.
Yeah, if you haven't, to the audience, if you haven't had a chance to pick up the paper by Tanuj, I think it's really interesting and might expand actually the area of research. And that reminds me of another question that came in about yoga, which is similar to the answer that you gave about scuba diving. If you think about it as everything in moderation, and Arthur showed the pictures of the different positions that could influence IOP in yoga, but there are many, many others that wouldn't influence IOP. So I don't tell patients to stop yoga. I tell them to maybe watch out for certain positions, but continue to do what they love to do. So we have ways to educate patients on ways to continue living, even with the disease process that they have. Just for the sake of time, I want to ask both of you a question, and I'll start with Arthur. Maybe a little bit of a controversial question, but I think one that all ophthalmologists and all patients are going to be thinking about. If you look at the video that Kaweh was showing, in the early stages, these implants can be quite invasive when you're putting them in. There are different versions. Of course, there's triggerfish contact lens, which maybe gives you a slightly different kind of data set. There's InjectSense, which maybe isn't as public with some of the procedural things that they do, but it's a smaller device and maybe placed in a minimally invasive way. Arthur, how do you think patients are going to receive these devices? Will it be something that all patients will be lined up to do and you would want all patients to do? Will it only be coupled with surgery in the operating room? What is the patient population that will actually see these devices and get use for them?
It's a good question. And I think that it will change over time. Certainly with larger, more invasive devices, it'll be coupled with other surgeries. It would be a hard sell to try to convince a patient to undergo a significantly invasive surgery just to place a device. But as the devices get smaller, I think there will be a shift. It won't be an immediate shift, of course, because there's going to be a learning curve on the part of providers, and there's going to be a level of comfort that needs to be achieved. But I think as the devices get smaller and less invasive, I think the long-term goal is I'd like to see this in all my glaucoma patients, and to just use the the analogy with diabetes. We can monitor diabetes, blood glucose at home. There's implantable blood glucose monitors. Once we can make that jump in glaucoma, I think we enter a completely different era of disease management, and what we'll learn and the level of care that we'll be able to provide to our patients will be unlike anything that we can do now.
Yeah. What do you think, Kaweh?
Well, I fully agree with Arthur. I think it will be a gradual change, but ideally every patient should have access to routine IOP monitoring. Practically speaking, in our center, since the new iMate suprachoroidal sensor got its CE mark in Europe, which means we can use it clinically, we have given our first orders for them. And the idea is to offer it to every glaucoma patient who undergoes filtering surgery. We haven't got reimbursement, so it will be out of pocket, but we believe it's useful enough and safe enough to offer it to every patient who has deep sclerectomy, for example.
Yeah, so it raises other questions, of course, because you mentioned reimbursement. Cost is a big issue. We're going to introduce a whole new issue about health equity when some populations are going to have access to these sensors and others won't. Organizations like Orbis, CyberSight are definitely at the forefront of trying to get to a better place from a health equity standpoint. This will be another challenge for organizations like Orbis for sure. And hopefully we can figure out a way to make sure that everybody benefits from the technology and the data that we get from the technology, because that's going to be a whole new area of what does it mean to have constant pressure checks, and what kind of medications and surgical devices might actually come to play when we have all of that data. So I want to start off here at the end of concluding this by just saying thank you to Orbis, thank you to CyberSight for hosting. Thank you to all of you who Zoomed in today, because everybody's busy. Certainly night hours in many places of the world where people came in to visit with us today. So I'm thankful for that. We will continue to do these point-to-points, hopefully every quarter, and I welcome suggestions for the next point-to-point. So you can send them into CyberSight and they'll pass them along to me. And I want to finish off by thanking Lawrence for doing a lot of the audiovisual stuff for us. And of course, Arthur Sitt and Kaweh Mansouri for spending time and sharing a lot of your past research and maybe future outlook on how we're going to take care of patients with constant measurement of IOP. So thank you guys. I hope we can do this again live where we see each other and grab coffee afterwards, but I appreciate the time, and please have a great rest of your day.